Okay, I think we are ready to begin the second annual culture lecture. And what I'm going to be doing today is to give you just a few ideas of how we've started to develop this over the past few years. But this is a work that's really been developing over 15 years with some of my friends like Francois Sauer and new friends from NASA and Internet 2. And we've been able to pull together this very strong group of people that's not only designed for this lecture, but also for the future. And I would really very much like to appreciate John Cutler and his wife, who set up this Cutler lecture series. Because when we started to do this, what we decided to do is, hey, this is great that we have 300 people here in this auditorium. Perhaps we can reach out to 100,000 people using new internet technology. I'd also like to thank very much William Brustein with this International Week and USIS, which I think is a very important model for global health and how we can set up a global health program here potentially in the future. And of course, the School of Public Health has been quite beneficial in the development of this project and the development of the future of what we've been developing. Now, the Supercourse developers on the left-hand side, which you can't read very well, but basically we've had a large group of people who've been working with us, students and faculty members from here, from Pakistan, from Mexico, and developing for the use of the internet. And what we've been doing, and we've been developing the system of this webcast, and we're distributing information to about 30,000 people worldwide, these lectures, in 151 countries. Now, the information formats, I'd like to present this because this is different than typical lectures. Because what we've done with Eric, and Eric is a very nice guy to allow us to work with him, is we said, well, what we want to do is try to set up systems so we can maximize our reach across the world. If we just did a webcast, we couldn't because the bandwidth is so high. People in Kenya couldn't get it, or people in Haiti couldn't get it. But maybe we can set up different systems like PPT or different types of files. So we've basically set up about 8 different types of files, and we'll send you information, as many of you know, how to use these files. And from the use of these files over the course of the next year, we expect that at least 1 million people will be learning from a single lecture. Now, this is important because it changes the ramifications of how we're teaching public health and epidemiology and science, because what we're doing now is thinking about approaches where we can get the best teachers in the world, like Eric Noji, producing the best lectures to reach the most people. And it's a very different model of teaching and education, but we're at this point with the internet that we can do this very cost effectively. And in addition to this, just came in today. It was very interesting. This is a friend of mine in Nigeria. It's really the impact of what we're doing today had an impact yesterday. Tony in Nigeria participated in the development of teaching students, about 200 students in Nigeria. He took Eric's lecture, which is on disasters, said, well, the biggest disaster in Kenya, biggest disaster in Nigeria is AIDS, and constructed an AIDS disaster lecture and ran a program and taught this lecture, Eric's lecture, to 200 people in Nigeria. To have that impact even before a lecture is presented, we're very, very proud of it. Now, if you'd like to join the Supercourse or network or contribute a lecture or ask questions of Eric, these are the numbers that you can look at, and you can also go to the Supercourse at this point. Now, this is really cool, and we have a lot of fun with this. And one of my friends, really good friends, his name is Ali, and he's in Iran. He's in Tehran. And right now, at this time, it's 2 o'clock in the morning in Iran, and he's having a Supercourse party. Isn't that cool? Okay, I'd like to now present our Dean of the School of Public Health, and he's going to be discussing the Cutler lecture.
Well, thank you, Ron. I'm Bernie Goldstein. I'm Dean of the Graduate School of Public Health. And before talking about John Cutler and introducing Dr. Noji, I wanted to say something about Ron Laporte. He's an extraordinary scholar and leader. We have a new title for you, Ron. It's Professor of Alchemy. The last professorship of alchemy was given in the Middle Ages. Alchemists have gotten a bad name at times because they try to change lead into gold. But what they really were trying to do was to use what were then new scientific and technical approaches to transform and transmute. And Shakespeare gives a wonderful example of how alchemists were thinking in the Tempest. He talks, full fathom 5 thy father lies, those are pearls that were his eyes. Nothing of him that doth fade, but doth suffer a sea change into something rich and strange. And Dr. Ronald Laporte has used today's technology to transmute and transform to make a sea change of what I'm sure will be a pearl of a lecture. But if not for Dr. Laporte, the lecture would be just to us. So, Ron, our new professor of alchemy, thank you very much. As much lead as you can convert into gold. Dr. John Cutler would be very pleased by this sea change. Before joining the Graduate School of Public Health as Professor of International Health, he was both Assistant Surgeon General of the U.S. Public Health Service and Deputy Director of the Pan American Health Organization. His global health activities focused on venereal disease control and on population health. His activities had a very high impact on health, and this impact has continued through his mentorship of people who are in this room and people who are throughout the world. All of what he did was characterized by scholarship and by his personal warmth and attentiveness. I want to particularly thank the Cutler Endowment Committee, who in his honor, after his death 2 years ago, put together this award. First, let me point out Dr. Elise Cutler, Mrs. Elise Cutler, did not get a doctorship, but I'm sure John would have considered you Dr. Cutler. John's widow, who has been a source of great strength for this school throughout. The members of the Endowment Committee are Dr. Michael Dalmut, Ms. Judith Cope, Mr. Terence Jazowski, Ms. Lois Michaels, Dr. Russell Morgan, Dr. Ravi Sharma, and Dr. Stuart Strahl. And again, thank you all. Dr. Cutler would also be very pleased by the choice of today's Cutler lecturer. Dr. Eric Noji is a physician serving as Senior Policy Advisor to the Director of the CDC, the Centers for Disease Control in Washington. He is responsible for working with Congress, the White House, and other executive branch agencies on issues related to health and medical threats to national security. His very distinguished past activities include service as Senior Policy Advisor for Medical Readiness in the Pentagon's Chemical and Biological Defense Program and in the Department of Homeland Security. Following the attacks on the World Trade Center and during the anthrax crises, Dr. Noji was assigned to the White House as an expert in the treatment of biological, chemical, and blast terrorism. In 2003, he served as Deputy Chief of the Medical and Public Health Unit for the U.S. Humanitarian Assistance Mission in Iraq. Before his Washington assignments, Dr. Noji was Associate Director for Bioemergency Preparedness and Response within the National Center for Infectious Disease. His 18 years at the Centers for Disease Control included 4 which he was on assignment to the World Health Organization in Geneva. There in Geneva, he was Director of Global Health Intelligence for Emergencies, and this including being responsible for monitoring the health of refugees and war-affected civilian populations throughout the world. Dr. Noji received his medical degree from the University of Chicago and his Master's of Public Health degree from Johns Hopkins. He is the author or co-author of over 200 scientific articles and publications, including the most widely used educational textbook on the public health consequences of disasters. Of note is that there's an award in his name. It's the Eric K. Noji Excellence Award, which is awarded annually by the Center of Excellence in Disaster Management and Humanitarian Assistance. It's to recognize exceptional teaching and educational achievements in the management of disaster response and peacekeeping. Dr. Noji is also currently a senior fellow at the Homeland Security Policy Institute at George Washington University, and he undertakes Homeland Security research and other projects. Among them, he currently serves as Special Assistant to the U.S. Surgeon General for Homeland Security and Disaster Medicine. Dr. Noji, thank you very, very much for being here and gracing us today.
Bernie, thank you very much for that wonderful introduction. I'm absolutely delighted to be here, especially in honor of Dr. Cutler. Very appropriate, not only that I'll be discussing the topic of public health consequences of disasters, but if you look through the development of the improvement over the last 30 years or so, the organization which has contributed the most to making disaster response, disaster public health preparedness really a science has been the Pan American Health Organization. And as many of you know, Dr. Cutler spent many years as Deputy Director of Pan American Health Organization, the American Regional Office of the World Health Organization. Of course, tragically, this lecture is also quite appropriate in that just the last 9 months we've had two of the most catastrophic disasters in global history as well as in domestic emergencies. Of course, the tsunami disaster last December in South Asia, and a month ago here in the southern United States, Hurricane Katrina, and now the after effects of Hurricane Rita. Basically, I've tried to organize this lecture more or less historically, how we've improved over the years through experience, through things we've done right, through things that we've done wrong. I tried to summarize that in a book I published by Oxford University Press about 8 years ago, and the second edition will be coming out in about 3 months. But to give you an idea of how our world has changed, when this book came out in 1996, many of you who've written books know that a book in many cases reflects writing which may have been 2 years before. So there is not one word on terrorism in this book. That alone makes this book quite out of date, and it just goes to show you the change that we've gone through, both socially, economically, and probably most important of all, psychologically. I've been in the disaster public health field for about 21 years now, and especially recently I've grown very, very interested in the history of disasters. I've always had an interest in the development of our response to disasters, the contributions of PAHO, the Centers for Disease Control, the academic community, but through history I've also developed a strong interest. And the reason I put this slide up because it reflects both issues which came up last month in Hurricane Katrina, but also reflects the very first disaster which I could find in the literature. And of course, this is, I guess you call it, the Great Flood, and represents one of the first successful community warnings, and a warning where civic authorities or a certain community individual actually acted upon that warning, and it was the first successful community evacuation. So it goes with, that's of course Noah, evacuating 2 of every species into the ark. So these ideas which we think are modern, like hurricane warning, evacuation, and sheltering, are certainly have been known for 5,000, 6,000 years. Of course, we have a success story beginning history, and we have failures. And many of you who have traveled in Italy could probably recognize this as the city, Roman city of Pompeii. And in the background you see the still active volcano Vesuvius, and this is an example of bad public and city management, where they knew for hundreds of years that Vesuvius was an active volcano, had destroyed cities in the past, still built a large metropolitan area there. In fact, another big city, Herculaneum, of course, in 79 AD, Vesuvius erupted and destroyed these 2 cities, primarily by ash. Archaeologically, historically, however, they're treasures, because some of the finest examples of Roman society and history were preserved in this eruption of Vesuvius in 79 AD. Of course, now we've got Naples in that area. We've got millions of people in that the environs of Mount Vesuvius, still at equal risk as people were in 79 AD. The last eruption was at, I think, about 1649. And then up to the present time, of course, we have our own tragic disaster, Hurricane Katrina in Louisiana, where many people don't realize that the most catastrophic disaster in American history occurred probably within an hour's drive of Hurricane Katrina's landfall. And this was a major hurricane and storm surge which hit Galveston in 1900. And there are actually still some people alive who remember that hurricane in 1900, which killed 6,000 people. So we've had Katrina, and 105 years ago, the biggest disaster we've had, the Galveston hurricane of 1900. And still, although we haven't determined the final death toll of Hurricane Katrina, at least at this point in time, the Galveston hurricane is the most severe disaster we've had, with 6,000 deaths. I just wanted to put this slide up because when I was first getting into the area of writing about disasters, documenting things I had seen in the field, I worked in disasters and used the word disaster, but I wanted to, in my first paper, put down the standard recognized definition of disaster. Well, I looked it up and came up with 700 definitions of disasters, really depending on the scientific field that would have been looking at these events. You looked at the seismology literature, geology literature, and they would describe disaster as a earthquake of such and such a magnitude, and it could be in a totally underpopulated part of Russia, and so it had, it was a major natural catastrophe. But I think for those of us in public health and in medicine, unless a hurricane like Katrina or the tsunami or like the earthquake in Iran last year, the BAM earthquake, which killed 35,000, 40,000 people, unless we really have an event that impacts a human community, I really don't think the geological or meteorological definitions are very good ones to use. I like this definition, which was first penned by the Center for Research on the Epidemiology of Disasters, what they call a collaborating center of the World Health Organization. I like it because it implies a catastrophic event, a vast ecological breakdown in the relation between humans and the environment, serious or sudden event on such a scale that the stricken community, so you've got an event, it affects a human community, and then finally that requires extraordinary efforts to cope with it, often with outside help or international aid. And very interesting about the current disaster, it's as far as I know, it's the first time that the United States has accepted international assistance from organizations like the World Health Organization and the European Union to respond to this disaster. So you've got three elements here. You've got an event, whether that's a hurricane, a plane crash, terrorist attack in a subway, affects a community of people, and it overwhelms the capacity of that community to effectively respond to the needs of its citizens. So if you look to the literature, you'll see disaster, you'll see emergency. Emergencies in many of the texts, for example, by World Health Organization, imply an event like a plane crash or a transportation accident that the community is able to effectively respond to. If you have a crash of buses in Manhattan, my goodness, they've got several trauma centers, and that's not going to really stress the hospital system in Manhattan. However, you've got many rural areas in Appalachia, many hospitals that they don't have a physician in the hospital at night, may or may not have a nurse, and you have that same bus crash in a rural area, and that could be a major disaster. So I've read other texts on disaster medicine where they define a disaster by numbers, greater than 100, greater than 1,000. I really don't like that because it ignores the capacity of the community that may or may not be able to respond to that number of casualties. Now, as epidemiologists, we like to classify diseases, and we like to work conditions that we see that cause public health impacts. And one thing I've tried to do over the years is to view disasters from an epidemiologic perspective, and to view each type of disaster as a separate disease entity, because they really do cause different public health and medical effects. And about 30% of my time at CDC and when I was in Geneva at WHO was spent in training and educational activities, and I would review disaster plans along the Gulf Coast of the U.S., in California, actually in Naples, the volcanic disaster plan, and a lot of them are just identical and don't take into account that a hurricane, as we've just seen, has a much different human impact than an earthquake does. Earthquakes could cause thousands of deaths, severely injured patients requiring immediate surgical interventions. Hurricanes, for the most part, cause, fortunately, very few deaths. You look at the 4 hurricanes that hit Florida last year, and I think the total death toll was about 10. Unless that hurricane is accompanied by severe flooding, what we call a storm surge, or in the unfortunate case of New Orleans, where the city is below sea level and right next to a lake with levees that break, you simply don't see a lot of deaths or severe injuries. Certainly transportation disasters, plane crashes, bus crashes, the crash of the Challenger, technological disasters, probably the 2 most famous in history would be the 1986 Chernobyl nuclear power plant disaster and the Bhopal chemical disaster at the Union Carbide plant in India. Now, if I had to say the 2 types of disasters where the U.S. government, whether we're talking about the White House, Congress, executive branch agencies like Health and Human Services, are focusing the greater part of their efforts on would be terrorism. Basically, if we did not have 9/11 and the subsequent anthrax releases, we would not have seen a increase in CDC's budget of to the point where our biodefense budget is greater than the HIV/AIDS budget. I mean, unbelievable. And once again, the importance of the psychological effects. We had 5 deaths from anthrax, 23 people sick, 5 people died, and look at the impact of that. A new federal agency bringing in 250,000 people, bringing in 22 federal agencies. We've got now the threat of pandemics and the threat of diseases not due intentionally as terrorism, but bird flu and SARS that are of major concerns. Natural disasters, unfortunately, since 9/11, have not been in our mindset as much as bioterrorism, when in fact we can be guaranteed every year we're going to be having hurricanes, we're going to be having tornadoes. I worked in California when we had earthquakes in Los Angeles in 1994 and in the San Francisco area in 1989. But you look at the last 10 years and from events like thunderstorms, floods, earthquakes, hurricanes, on a global basis. I mean, just thousands of these events, and you can be guaranteed that we're going to be hit next year by a hurricane or an earthquake. And unfortunately, with hurricanes, it's going to be probably just as bad. Because we've been very lucky the last decade in that even though we've had major events like Hurricane Andrew, Hurricane Hugo, Hurricane Gilbert, Hurricane Mitch, Opal, Marilyn, Francis, Charlie, this was actually a low period, and we're actually now going back into the normal pattern of hurricanes that were seen in the 1930s and 1940s when we had direct hits on Miami, Houston, and and New Orleans. So people say, oh my God, this must be global warming. That's why we're having so many hurricanes. We're just basically going back. It's a cyclical process. When you have the end of a drought in Western Africa, that tends to result in formation of tropical depressions. And if you look at, on the weather, it was amazing last year. It was like Kennedy Airport with 6 hurricanes lined up from Africa all the way to the Caribbean. And with the drought ending in parts of Western Africa, we're just going to be seeing a lot more hurricanes than we did in the 1980s and 1990s. Disasters, and I should have put down natural disasters, our process, which, as you see here, are not getting better despite our improved technology, but are getting worse. Now, I have to put a caveat in there, in that we're not going to be having more earthquakes or more tornadoes or significantly more hurricanes or volcanic eruptions. But in the next 10, 20, 30 years, we have more people, much more people, and unfortunately people who are poor, who cannot afford what we call engineered living construction. They're self-built. They're living on shanty towns, on hillsides in Caracas or Jakarta. So we've got more people now at risk in the next decade or so. And as a result of that, more people are going to be affected by these catastrophic events. Not because we're having more earthquakes or floods, but unfortunately, many more people and many more poor people for a variety of reasons. And I like this slide because it points out that to really have a good understanding of the disaster phenomenon, even those of us in public health, requires a multidisciplinary approach. Either a person who has a good public health knowledge, but also in terms of studying sociology, economics, environmental effects, because and demographics, because many of these points which I have up here are normally not studied in medical school. When we've got human vulnerability due to poverty, social inequality, political science, environmental degradation. Best example I can think of that is mass deforestation of areas which 200 years ago, if they had a tropical storm, would have caused no deaths. I've done a lot of work in the Philippines, Mount Pinatubo. Disaster which a lot of people don't hear about was a lot of forest trees are being cut down on the island of Leyte. And 1 year after the eruption of Mount Pinatubo in June 1990, there was a tropical storm which hit Leyte and 6,000 people drowned. Well, Leyte, a lot of lumber companies from Japan and other parts of the world, they pretty much deforested a lot of the island. And when this tropical storm hit, that caused a massive flooding, and 6,000 people drowned. Finally, as I mentioned before, rapid population growth, especially among the poor. And if you look demographically at who has taken the greatest brunt of disasters, deaths, disability, they're the poor or socially disenfranchised. This is very scary because not only are we having more people in the world, we have a phenomenon that you'll see in every continent where are these people moving for economic reasons, recreational reasons? We are seeing this in China. 1920, about 100 million people lived in cities. By last year, 2 billion people lived in cities. 20 cities, greater than 10 million people. And if you look at this carefully, what cities are these? These are cities that historically have been hit by catastrophic earthquakes. These are cities like Jakarta, Manila, Rio de Janeiro, Bombay, Kuala Lumpur, Shanghai, Mexico City. And we're going to see a phenomenon of many more people concentrated in small areas, and many more people living in areas at very, very high risk for natural catastrophes, earthquakes, hurricanes, floods, etc. I won't go into this, but this is a major field in itself. The insurance industries, the reinsurance industries. In fact, when I was doing some of my early papers, some of the best sources of morbidity and mortality data were the annual reports, put out by Munich Reinsurance and some of the other insurance companies, because not only would they put out economic losses, they would put out the best estimate of deaths and lifelong disability. We've seen, I think, when you talk about the public health impact of disasters, what I've seen at least in the last 20 years, and my first really big humanitarian event that I volunteered for, we're at the exact 20th anniversary, and that's the big Mexico City earthquake of September 20th, 1985. And in the past 20, 25 years, we've seen the growth of, basically, it's the business of humanitarian assistance. Disaster relief, humanitarian assistance is a $10 billion a year business, basically, with, you've got lots of NGOs like Doctors Without Borders and French Médecins Sans Frontières. They received the Nobel Prize 2 years ago. The Red Cross, International Rescue Committee. We've got every single UN agency with a disaster unit, the World Health Organization, Pan American Health Organization, UNICEF, UN High Commission for Refugees, UNESCO. You might say, well, UNESCO, I thought that was protection of cultural artifacts and architecture. Well, there's a big business on protecting museum pieces. One of my best friends is a professor of civil engineering at USC in Los Angeles, and his career is spent on working with the Getty Foundation on Los Angeles, earthquake country. If there is an earthquake, we've got priceless art here. And so he's developed these very ingenious wheels on the bottom of Michelangelo, so that if there's an earthquake, and they got the same thing in the Louvre, in the Prado. So UNESCO, a big disaster unit. We've got governments, U.S., we've got FEMA. Of course, you all know FEMA now. They've been on CNN the past couple of days. Well, we're on, I better not say. We've got donor agencies, UN agencies, non-governmental organizations, and you can see the flow of money. Governments basically funding non-governmental organizations to provide medical care and water and sanitation and shelter. So I called, and during a disaster, and we saw this in Louisiana and in Mississippi. I've been in this business 20 years, and I've never been so confused in my life. And they call this the fog of relief, and this is just from trying to keep track of all the organizations involved. And I'm not even talking about, in this slide, the greatest number of people who respond to a disaster are volunteers who aren't members of these already established organizations. These are people out of the goodness of their heart. They get in their car and they just drive to Louisiana. And they globally they pop up in the tsunami disaster in Indonesia. Literally thousands of doctors and nurses not affiliated with organizations just showed up. And you might say, well, so what? I mean, that's they've got good hearts, but they come unprepared. They're not self-sustaining. They have no water. They've got no shelter. They've got no food, and it's really a disgrace when you see them being fed by the victims of the disaster, who are very hospitable, sharing their food, sharing their houses with people who came there to ostensibly help them. I call that the second disaster on a disaster, and that's the descent of thousands of volunteers who actually do more harm than good. Natural disasters, of course, a lot of us are thinking about that right now in the aftermath of Katrina and Rita and the tsunami disaster and the Iranian disaster last year. But this was a major change in my own career, where before the early to mid-90s, my whole career was on natural disasters: Hurricane Hugo, Hurricane Gilbert, Armenia earthquake in the former Soviet Union. But here once again you have a major social, political upheaval: the fall of the Soviet Union, collapse of a social and economic structure, which also freed what are called client states, which had been held in check by Soviet power, and a lot of the ethnic tensions and hatreds, which you would think would have disappeared over the past 50 to 100 years. Classic example, the former Yugoslavia, a country since the end of World War I. You have the secession of Slovenia, Bosnia, former Yugoslav Republic of Macedonia, and Croatia, and political destabilization in the heart of Europe. More so in Africa, where we both had client states. Breakup, civil war in Ethiopia, Sudan, Somalia, Portuguese left Mozambique and Angola. And so from about 1994 through 98, all of the disasters I was involved with involved wars, providing humanitarian assistance to civilian populations in countries in the Balkans and in Africa and Central America, Guatemala, El Salvador. But disasters which we now call complex humanitarian disasters, disasters that are caused by economic, social, or political change, escalating ethnic-based conflicts with civilians as the primary military targets. And that was my job, was to provide public health and medical support to civilians, and for the first time I had to learn about international humanitarian law, human rights, atrocities being committed against civilians in the former Yugoslavia, testifying. I had never, going to medical school in my public health training, I had never ever thought that I would have to study law, and that I would be called upon to testify for crimes against humanity, bringing back, I'm of course familiar with the Nuremberg trials after World War II, breakup of the Soviet Union, Chechnya, actually not the breakup, but Chechnya is still part of Russia, and we have the problem of forced migration. I've worked in famines in the 1980s, but those were primarily caused by climatic changes, drought, inefficient distribution of foodstuffs, and we're at the 20th anniversary of once again probably the first time that the Western world became aware of a lot of the problems in Africa, and that was a result of Live Aid. And now we've had other performances of Live Aid, which have brought the attention of the world once again to famine and major problems in Africa, mass population movements because of civil conflict within their countries of origin. This is the movement of Rwandan refugees from Rwanda to eastern Zaire, and we had 1 million refugees move within a 24-hour period to the west into, at that time, Zaire, and into the east into Tanzania. We had CDC staff in that area for over a year dealing with this situation. Absolute catastrophe, which is a lecture in itself on issues of sanitation, water. We had a cholera outbreak, I should say diarrheal outbreak, because I personally think most of the deaths were caused by Shigella, but about 50,000 people died diarrheal disease within a 3-week period. Big problem now. Before at CDC, and we've got a 40-year history of working in public health consequences of disasters, natural disasters, but even in war, when we had CDC staff working in Thailand during the Cambodian movement in 1979, when the Vietnam Army moved into Cambodia, and in Afghanistan, we had camps in Pakistan, in Peshawar and Quetta, relatively safe because you're really not in the field of battle. But now we have our CDC staff working in places like Sierra Leone, Liberia, East Timor, and we have a situation of armed conflict by non-state actors who, they never heard of the Geneva Conventions that respect the responsibilities of physicians and healthcare providers. The Red Cross means nothing anymore. I mean, one of the most terrible experiences I've had was friends who were working for the International Committee of the Red Cross in Chechnya, Red Cross, and in the middle of the night, who knows, broke into the Red Cross compound and assassinated all 6 of them. And so even the Red Cross, Red Crescent, which for 100 years has been a symbol of humanity, is no longer respected. We've got generation now. I mean, in Sudan, if you read, you've got a civil war in Sudan that has been going on since 1955. We had a situation in Beirut, civil war, 10, 15 years. The the problem of child warriors, of soldiers, integration now, of which UNICEF is taking the lead, reintegration of children who have known nothing but violence. I'm an emergency physician by training. I have a lot of experience in training and treating adult gunshot and violent wounds, but we really had no experience up until Afghanistan of the treatment of children who have been injured by not civilian weapons, which you see all the time here, but by military weapons, and we saw that in Afghanistan and in Africa, and we had no textbooks on how to treat children injured by military weaponry. And finally, Robin Copeland, we owe a great deal of debt to him. He's a surgeon who works for the International Committee of the Red Cross, wrote the first textbook on the care of children in war. A major work. Landmines, once again, it's a problem that I guess one of the tragedies is you could have had refugees who survive 10, 15 years outside of the country. They return to Cambodia, they return to Mozambique, Angola, with millions of landmines still, and it's terrible. You've survived the war only to get your leg blown off, like this woman returning home after surviving years of exile. As I said before, humanitarian workers, and unfortunately we've had CDC staff kidnapped. I was working here in Gaza, and some person shot the front wheel of my tire out, and knowing full well that I was a doctor, and had to be accompanied by armed guards. And of course, a lot of our success at CDC over the years has been our feeling of neutrality that we that people thought we possessed, but now having to be accompanied by soldiers, and many times wearing protective equipment, scares people, and we lose that element of neutrality, which was the only way that we could provide humanitarian assistance. So after I got my tire shot out, my effectiveness working in the West Bank and in Gaza was over. It's types of disasters in the mid-90s were, as I said before, these complex humanitarian emergencies. I was deputy chief medical officer in Iraq, and not military, but following the advance of coalition forces until Baghdad, and having to wear protective equipment, that also made providing public health services and medical assistance to the Iraqi people very, very difficult, because these people, particularly in the south, the Shiite population, who had been persecuted for years by Saddam, they associated uniforms with police and the army, who were basically murdering them, and by the thousands. And once again, dressed like this made it very difficult to provide humanitarian assistance. And we tried to summarize this in a article in Emerging Themes in Epidemiology last year, the role of applied epidemiologists in armed conflict. I never would have believed this when I first got into disaster public health, that there would ever be such an article like this of epidemiologists, both as targets, but also there were good things in this paper too, that epidemiologists and nurses and physicians, usually very respected members of the community, we also were a very important instrument of bringing warring parties together. I started a program in Geneva called Health as a Bridge for Peace, and pilot tested that in Bosnia and in Angola, and trying to use the medical and public health community, bring them together. Yugoslavia, these were colleagues before the war. They were friends. They'd gone to the same schools in Yugoslavia. But a problem that unfortunately I don't think will go away, and for epidemiologists particularly, you know, those of us in public health, we're very activists. We want to do things. We want to help people. Unfortunately, even recently, and even today, in Darfur and Sudan, humanitarian workers are at great risk. Over the last several years, unfortunately, it makes me very depressed, is that things that have been observed over and over again, they've been written up in The Lancet, in very prestigious journals. We make the same mistakes again. Here we go. External medical volunteers with any kind of medical background are needed. Everyone thinks that. The more doctors and nurses you have, the better. But remember, many of these good-hearted people have never worked outside of a hospital. They come from Mass General, they come from the University of Pittsburgh, working in the deserts of Sudan or jungles in Rwanda. They could very much be a liability. And when in fact the reality is the local population almost always covers immediate life-saving needs. Only skills that are not available in the affected country may be needed. And an example I have is when I worked in Armenia, hundreds of surgeons arrived, but a week later, and what good are they? I mean, the immediate life-saving operative interventions were, unless you do that within the first 24 to 48 hours, the efficacy of surgical interventions is nil. But where they are of value is in rehabilitation, reconstructive plastic surgery, which was not available in that country. So the bottom line is, and I can tell you, donors like some of the people who I work for don't like to hear this, but few survivors owe their lives to outside teams. Most people are saved by friends, neighbors, local medical community, but you now have the interrelationship of humanitarian assistance, politics. As I said before, the public health consequences of disasters is getting very competitive. You've got the European Union with major disaster units, the United States, Japan, Scandinavian countries. Whoever is there first plants their flag in the earthquake zone or in Sumatra. They're usually getting a lot of credit because really the first people there are CNN and BBC. And basically they see the British there first, and it sounds funny, but it is harmful because they usually arrive without doing a good epidemiologic needs assessment. And what's the result of that? That's inappropriate provision of supplies, equipment, and medications. And that's what the purpose of this slide is. The myth is any kind of assistance is needed, and it's needed now. When the reality is a hasty response, which we've recently seen, and we saw last year in the tsunami, not based on an impartial evaluation, only contributes to chaos. Unrequested goods are inappropriate. They divert scarce resources. People who have to go through all these medications in foreign languages. They're expired. They're in the brand names. They have to be destroyed. And when I mean destroying medications, that's just not burying them. That's very expensive incinerators to get rid of the drugs. I worked in Bangladesh during the flooding in 1988, and people were sending, instead of sending their down coats to the Salvation Army, down coats to Bangladesh. The average temperature all year round is 95 degrees. Birth control pills, high blood pressure pills, anything in the cabinet. There are some fantastic articles in the Lancet New England Journal on just simple inventory of what's sent to disasters. It's interesting reading. Here once again, where do you put all this stuff? This was in Kobe, Japan, after the 1995 earthquake, and this could have been used as evacuation point or hospital. But that's where they put all this junk arriving from all over the world. Medical students, nurses, diverted from helping people, sorting through drugs and medications. Here, I've given up on this one. I probably spend 90% of my time in disasters on the phone with people calling up with, we've got cholera, we've got Ebola virus in New Orleans, and I worked in Turkey after it's not just the U.S., but rumors of epidemics, rumors that dead people are going to be spreading contagion. Basically, I can't. Here's the book. I tried to. There's a chapter called Communicable Diseases in Natural Disasters, and I reviewed the record for the last 50 years and only found about 5 or 6 natural disasters where there was what I call a significant epidemic of life-threatening proportions. But no matter how many times we have education for the press, the media, and I really got depressed during the tsunami when there was a CNN flyover over Sri Lanka, and some very good physicians, in fact, very well-known one for CNN was, and I won't mention any names, was saying, oh my God, there's going to be outbreaks of meningitis and malaria and this and that diseases which had never been seen in Sri Lanka. Once again, spread throughout the world, and particularly by a physician. I mean, that's very damaging. And then that starts public health authorities to implement mass immunization, which could be harmful. And it was harmful in the Mexico City earthquake in 1985 because the preparation used at that time was the parenteral form, and there are major complications from the parenteral shot of typhoid, and more people. There were no cases of naturally occurring typhoid after that earthquake, and they don't remember that you need more than just one vaccination. No one came back for number 2, number 3. But I got to say that being in public health and epidemiologist, there's not much we can do which is very looks good on TV, except sitting in front of a computer, I guess, and type. It's not like these fancy search and rescue teams with their dogs and their fancy equipment and field hospitals and surgical teams. I mean, what can a public health person do in a disaster that looks good on TV? Immunization. It looks good on TV, and it shows that the government is doing something, and still see that in this country. You have a flood, and everyone gets immunized against a tetanus. Dead bodies, once again. That will always. I took this picture in Leninnikon in Soviet Republic of Armenia, and amazing sight. This is the main road into downtown Leninnikon, and as far as the eye could see on either side of the road were coffins and caskets. And I must say, at that time, the Soviet authorities were incredibly efficient. The bringing in troops, material within 3 or 4 days, 40,000 caskets. Very impressive logistics at that time. But, you know, when the press and the people see all these caskets, first thing they think of is epidemics. When the president of the country, here it says epidemic feared, Gorbachev asked removal and quick burial of quake dead. This also a very historic event. First time since World War II that the Soviet Union specifically asked for assistance from the United States. World War II, we were giving assistance ships going over at great danger over the Arctic. But it just so happened that Gorbachev was in New York City with President Reagan, and when the earthquake happened, and President Reagan offered assistance, and Gorbachev accepted. So it was very interesting flying into the Soviet Union. I was on the first plane, and it was a military plane, and it was kind of scary flying into Soviet airspace. Mexico City, once again, finding place for caskets, the smell, pestilence. Here, we think that everybody is shocked and can't do anything and is helpless, and we need to provide immediate and do everything for people. When in fact, in most disasters, people, at least first, they're able to handle much of their own needs. They're focused. They do a good job. They're well organized. A few days later, when things hit them, houses down, properties destroyed, friends are dead, that's when I start to see some major breakdowns but immediately, I have never seen a disaster where people are just, too shocked to do anything, and they're walking around like zombies. Like here in New Mexico City, this was a wonderful example of the people of Mexico City coming together and helping in the search and rescue efforts. And it was actually friends, relatives, and civilians who made most of the live rescues in Mexico City. Before the disasters, there's things we can do a better job of knowing what type of disasters are most prone in that area, what is the vulnerability of these communities, training and education, and of course hurricanes. We're going to see more of them. Fortunately, we know where these hurricanes are most prone to hit. We've done a lot of work on identifying vulnerable facilities, what we call lifelines, gas lines, electricity, water, sewage. What a lot of people don't realize going into earthquakes is just above this is the New Madrid seismic zone, where the most catastrophic earthquake in U.S. history occurred in the winter of 1811, 1812. 8.6, 8.7 on the Richter scale. Fortunately, and this was just about 100 miles south of St. Louis. And fortunately, at that time, the major population sector there were prairie dogs and squirrels. Now we've got St. Louis, Memphis, Indianapolis, Little Rock, and lots of people. And we've got major oil and petroleum lines underground going from this area up into the north. Flood hazard maps. We've got to do a better job planning evacuation. We get a good warning, but if we can't evacuate them, what good is it? What good is it? Knowing that we have hurricanes, at least from a public health perspective, spent pretty much my whole career looking at the specific health effects of earthquakes and war and terrorist attacks, both what are the effects immediately and long term. I'm still working on a cohort study with very good epidemiology. He was my advisor at Hopkins, Professor Armenian, on a long-term study of the psychological effects of the 1988 earthquake. It was, and chronic diseases, because it was very shortly after the '88 earthquake that the Soviet Union fell apart. And all of the workers who were brought to Armenia from Latvia and Uzbekistan, Kazakhstan, Siberia, they all left. And so very few of the healthcare sector hospitals have been rebuilt. And we've seen, and we published this, that higher instances of mental health disease, cancer, heart disease, diabetes, in the survivors of the earthquake. I wish, I'd just like to conclude that I wish that disasters were as easy to respond to as this slide demonstrates. But I hope I've been able to give a flavor of some of the problems that we face as public health professionals. Takes a lot of patience, a lot of rumor control, working with the media. Most of us have never worked with intelligence services. I've never worked with fire services, paramedics. We learned a great lesson after 11 September in Washington, D.C. At that time, I had set up Secretary Thompson's command center and was detailed first to Secretary Thompson, and the day I was supposed to go home, anthrax cases were going down, was when Governor Ridge, when you all, if you're Pennsylvania residents, know Governor Ridge became the first White House Homeland Security Director. I was assigned to be his advisor for the next 6 months. And working at that level, working at the ground level, different challenges, but I think it just goes to show you that the role of the public health professional is very vast. I think when we train our public health students, and particularly now, many of our students at Pittsburgh and Hopkins, and they have a very strong interest in getting into this field. And it's more than teaching them biostatistics and epidemiology. It's working with the media, rumor control, lots of things which, no matter how good a job you do epidemiologically and scientifically, and the staff we had our best epidemiologists in Washington, D.C., and we did not do a very good job in our media relations, and many people perceive that response as a failure. Thank you very much. Once again, I'm very honored to have been asked to speak in honor of such a distinguished man as Dr. Cutler, and wish you all the best, and hope to come back to speak someday here in your beautiful city. Thank you.
Okay, we'll take a few questions. Now, if you raise your hand, you have to speak into a microphone so that China can hear you.
Rashid Chatani from Hopkins. A quick question.
You're a friend of mine, so this has to be not a hard question.
No, it is not going to be a hard one. There are two things that I would appreciate if you could reflect upon. One, the specific notion that chronic diseases are not a critical problem post-disaster, which in my experience I found to be a critical problem also in adult population. The second one, which might be a little tricky, the role of military in disasters.
Thank you. First question. I did not mention it because otherwise, but in particularly hurricane disasters, when you have, and there's not that many deaths, but you have a lot of people in evacuation camps, a lot of elderly people. They can't get, the pharmacies are underwater, their private physicians are not there, they can't refill their insulin medication, high blood pressure, heart disease medications. You have people on dialysis, and we're having that problem. I think the biggest problem in my experience in hurricane disasters has been chronic diseases, without a doubt, and that is how to manage people with those types of disease who can't get cancer patients getting chemotherapy, impossible. And then in the long term, there are a lot of theories, but people who have experienced terrible things, both in war and in natural disasters, they, at least our studies in Armenia have shown a higher incidence of chronic diseases. But immediately, and this is one thing that a lot of people don't realize, because the stereotype is that we need surgeons and emergency physicians and blood and intensive care. That's not what we need. We need that in earthquakes, because you do have that severe trauma. In Hurricane Andrew, Hurricane Hugo, when not much was known, they sent a lot of surgeons, and there wasn't anything for them to do, because there was no one seriously injured, and what they needed was primary health care. Mother-child health care, elderly people getting their insulin, and I would like to hope that our national volunteerism, there are a lot of new volunteer teams are being formed, that these issues, that one size doesn't fit all, is necessary, because each disaster is a different disease. Military, internationally and domestically, if I had to, actually, I think predict. I think Dr. Laporte told me this. Military is going to take a very strong role, if not the lead role, both domestically and internationally. I wrote an editorial, second author in The Lancet last July, describing my experience as a civilian U.S. government humanitarian disaster relief worker, working with the Pentagon and the military, and we've got a lot of hard work to do to coordinate better, to learn each other's culture, but just basically talking with each other, because we had two planning offices, and coordination on site from day one of planning to Baghdad was a major challenge. And if you want to learn more, it's in this Lancet article, and the editor, that guy, he cut out 90% of the text. So we got the rest in last week in a journal called Third World Quarterly, which is a three issue. So hope that doesn't get me in trouble. So if the next time you're in Washington and you see me cleaning tables off in Chinatown, that means
Tom Sunger from here in Pittsburgh. We can't let a question from Hopkins go unanswered. What are the myths and realities related to mental health following disasters?
I think that there were, early in my career, there were, I'm not sure if I call them myths and realities, but one of the issues was that psychological impacts were primarily a problem of the people in the community affected by the disaster. Now we know that there are major problems with responders. Police, fire, rescue. I found this very amazing that even battle-hardened soldiers 82nd Airborne in going through New Orleans found this. Some of them said this is the worst thing they've ever seen, and that led to a great deal of research on the effects of disasters on first responders and doctors, and in a bioterrorist attack, the first responders are going to be, hospital personnel, because they're not going to come to the hospital by ambulance. They're going to show up in emergency rooms, and then there's studies of effects of ER personnel over the years. But I'd say that's the major one. But now, so much work has been done on behavioral and mental health consequences of disaster. We've now finally got funding sources to fund this research at good amounts. That I can't really think of too much more missing realities in mental health.
I looked this up in the internet not too long ago about Louisiana, about volunteering, and they really didn't want surgeons. The state board, they didn't want surgeons. They wanted hospitalists, they wanted physical therapists, and they wanted psychiatrists. Maybe you answered that in a sense in the previous answer.
I don't know about that, about the needs, because if you looked at the whole disaster impact area, huge, and the needs in one area were very, very different from another area. But in general, in hurricane disasters, flood disasters, tornado disasters, a surgeon, hope there's no surgeons, would be very bored, because the type of healthcare providers who are the busiest are the primary family practitioners, mental health professionals, without a doubt. I don't know about hospitalists, because there are team coordinators, and they may have a role in disasters, particularly maybe in a terrorist attack, in a hospital setting, where you do require a team effort of many specialists working on a patient. But I've never read anything about the role of a hospitalist in a disaster. But interesting.
I think we're going to have to call it, because there's going to be a class in here in just a few minutes. We had the email you can send, and Eric is very, very pleased to answer any emails.
You said there was another email that's going to be not my
It's going to come to ours, and we're going to screen them and then send them to you. We didn't want you to get that. 83 trillion. We don't know what the yield is going to be. We're going to imagine it. And I think before I thank him, I want to say, hi Yang, hi Silvano, hi Rome, hi Italy. It's kind of a nice feeling knowing that you can reach the world. Okay, just one quick thing before
I give my thanks also, but there is a reception upstairs, and you have a chance to talk some more to Dr. Noji up at the reception. So, again, thank you very, very much.
Very much.
Eric, and also the Cutler Committee again for their support of this effort. Great job.